Well, thank you for everybody who's elected to join us this afternoon for this AUA educational webinar. We're going to be talking about apalutamide in metastatic castration-sensitive prostate cancer, and this is a case-based discussion. This disclaimer is this is an educational opportunity on behalf of Janssen. It's not certified for CME. The consultants and speakers have been compensated for their time and speaking, and we're sticking to the FDA label requirements applicable to apalutamide, and this is all presented on behalf of Janssen as an educational opportunity. Some key safety information that will also be reviewed at the end of our discussion. There are several warnings and precautions for ERLEADA apalutamide, including CVA, ischemic cardiovascular events, falls, fractures, seizures, some severe cutaneous adverse reactions, such as extensive rashes and embryo-fetal toxicity. The most common adverse events that happen more than 10% of the time and 2% above placebo in randomized placebo-controlled trials are listed in the second paragraph here: fatigue, arthralgia, rash, decreased appetite, fall, weight decrease, hypertension, hot flashes, diarrhea, and fracture. And we will spend some time on safety information and side effects at the end of our discussion today. So I'll introduce myself, David Morris. I'm the president and co-director of Advanced Therapeutics Center at a large urology practice, private practice in Nashville, Tennessee, and helps coordinate our research trials department in prostate and kidney and bladder cancers. I'm joined today by Dr. Mao, who I'll let introduce himself and then kick us off.
Great, thanks, David. Judd Mao here. I'm a urologist at Duke University Medical Center in Durham, North Carolina. My practice is focused primarily on prostate cancer. I've been at Duke for 20 years, and prior to that, I was a urologic oncologist at Walter Reed in the U.S. military. So I'm really honored and delighted to be here supporting the AUA and supporting this educational effort. So the objectives of this program is to discuss the effectiveness and safety data of apalutamide plus androgen deprivation therapy in metastatic castrate-sensitive prostate cancer, including subgroups of patients from the TITAN study, to review exploratory data evaluating the relationship between PSA response and overall survival in the TITAN study, and to discuss the key criteria in the therapeutic decision-making for patients with metastatic castrate-sensitive prostate cancer through review of patient cases. And I would say that this is a really important topic for us as urologists and urology providers, because we are seeing patients with metastatic prostate cancer, and one of the themes that we want to discuss is intensification of therapy beyond ADT alone. So I'm going to first discuss the TITAN study overview and some key data. The TITAN study is basically a randomized trial looking at modern era combined androgen blockade. In other words, we've known for 30 years that adding something to LHRH agents or orchiectomy improves outcomes. So for more senior urologists, they may be familiar with some of the combined androgen blockade studies from 20 and 30 years ago. The TITAN study builds on that, studying a more potent oral anti-androgen called apalutamide. And the study was designed similar to previous studies on combined androgen blockade, taking men with metastatic prostate cancer. So it would be someone walking into your office who unfortunately probably has a high PSA, and you do a metastatic workup and they have metastasis, and you're faced as a urologist with starting them on treatment. And this was a 1-to-1 randomization between ADT plus apalutamide orally or ADT plus placebo. And the dual primary endpoint was overall survival plus looking at radiographic progression-free survival. These men were on average about 68 years old. Almost 2/3 of them had high volume disease. 2/3 of them had higher Gleason scores greater than 7. About 80% of these patients had synchronous disease. In other words, about 80% just presented de novo with metastatic prostate cancer. 11% were previously treated with chemotherapy, in this case docetaxel, and 12% of patients had visceral metastasis. So 12% of patients had pretty severe disease already involving organs.
Judd, do you feel that those numbers reflect your fairly typical metastatic patient walking into your clinic?
Pretty much. I guess of course, I'm in Durham, North Carolina. We have a fairly large underserved population of younger African-American men. This study was a global study, so I would probably see a slightly higher proportion of younger men, which is even worse. I mean, sadly, we're seeing too many younger men with prostate cancer. What about in Nashville? Does this fit your patient profile?
I think especially with our current imaging, high volume disease tends to be more common. Synchronous or de novo disease tends to be more common. And obviously the higher Gleason scores just fit hand in hand with that. And I think there's a fairly typical patient population that I'd expect to see in the US.
I mean, I think the thing that we want the listeners to understand is, think about someone in your practice who sadly comes to you for the first time and they have advanced and metastatic prostate cancer. And we just want to make sure that people know that ADT alone is not sufficient. So we want people to understand that certainly apalutamide, we hope, is their first choice, but this is one of the options to add to ADT. I don't want to get ahead of ourselves, but here's the bottom line take-home message. This trial was a positive trial. Apalutamide plus ADT demonstrated superior survival versus ADT alone, and it was a 35% reduction in the risk of death. And so this trial really for the first time delivered a true unequivocal survival benefit in metastatic prostate cancer, where we were adding a pill, if you will, apalutamide, to LHRH agents for the most part, and improved survival kind of beyond a shadow of a doubt. The next data looks at the crossover data. In other words, in this trial, when patients progressed on placebo, they were able to receive the active drug apalutamide. And if you try to take that crossover into account, the risk reduction of prostate cancer was 48%. So we see an adjustment for the better survival. Dr. Morris, do you have any comments on the crossover analysis?
I think any trialist would tell you the crossover unfortunately makes analysis more challenging because so much of our modern oncology trials deal with subsequent therapy. And let's be honest, to keep someone on placebo when you know that the outcome is going to be better on an active agent is not ethical. And so they allow patients either on progression to go on to get subsequent therapy, or when a trial releases and shows how positive it is, they'll often cross the patients who are on placebo onto whatever investigational agent they've been studying, such as apalutamide. So you can kind of see where the data point cut happened 2 years in was basically when people had the opportunity to then get on combination therapy and intensify. And basically you can see the separation in the curves from the placebos that would theoretically not have crossed over versus those that did cross over. And there's added benefit even starting it later to getting on an active drug. But I think that, yes, it's hard to analyze, but it definitely suggests that earlier therapy is better, and the effect would have been even larger had you not allowed people to then get on medicine down the road, even when you knew it was better for them. So it just makes all of these oncology trials harder to run and to get some sort of meaningful outcome at the end.
Now, Dr. Morris discussed some of the safety information right at the front of our program. Here is some top-level data on safety. I'm not going to read this slide in detail, but the key teaching point is that the safety in the Titan trial was very similar to the previous Spartan trial. The Spartan trial was in non-metastatic castrate-resistant prostate cancer, and we've had that data now for close to 5 years. There were really no new safety signals seen in the Titan trial, but nevertheless, we have to be mindful that this drug does have some toxicities. The most prominent one that we see is the risk of skin rashes, and that can occur in 20-some% of patients. I think it's worth just spending a minute on that. Now, I would just ask Dr. Morris, in practical terms, when you are faced with a patient who has a skin rash, what is your practical advice or management strategy?
Well, it's also one of those issues that as urologist, if you don't ask about a rash, then you often are not catching a rash, and it may potentially then progress to a rash that is more challenging to take care of. So we get proactive with most of our patients on Erleada and ask about skin issues, topical treatments, oral antihistamines if there's itching associated with it. Very rarely oral steroids required. Usually managed honestly with topical therapy, and if that doesn't work, then a drug holiday or a dose reduction resolves most of the rashes. And if they do resolve, a good chunk of patients can be re-challenged and actually not have the rash come back. So I think we've become much more comfortable with what rash may mean as a group of urologists managing this disease, where at first, when it first came out, rash seemed overwhelming, like we don't know how to manage a rash. But in reality, it's become fairly straightforward to be proactive with it.
So I'm going to turn the podium, if you will, over to Dr. Morris.
Sure, thank you. We'll jump into a couple of subgroup analyses that have to do with disease volume, but we also have a patient case to start here. All right, so here we have a 68-year-old man, newly diagnosed, high risk, high volume metastatic CSPC. And you can see here just some social issues around him. He's not really sure how he's going to be able to manage this himself in terms of his own health care. He doesn't have as much support structure at home, which can be a big impact on just overall care for these men progressing as they age. But he's fairly young, and to be upfront about that is difficult often for those men. You can see high risk, Gleason 9. He has a very high PSA of 85 at diagnosis, some mildly symptomatic bone pain, has a workup including conventional imaging. It shows 5 pelvic and spinal bone mets and 1 liver met. So that would confirm him as metastatic. It confirms him as castration-sensitive because he's not been on any ADT therapy thus far. And treatment considerations for him that might kind of push us one way or the other. He is interested in intensifying. The urologist has been very upfront about the potential benefit in terms of survival, but he does have diabetes and hypertension as a potential comorbid disease impact on what the choices of therapy could be. So, Judd, does this seem like a fairly typical patient for you presenting into clinic for a discussion?
Yes and no. I mean, seems like I have 2 extremes. I certainly have patients like this, particularly some of the younger ethnically, African-American patients or patients with low socioeconomic status or low literacy rates. And we care for those patients in our practice. And sadly, because of delay in diagnosis and delay in access to healthcare, we see patients like this. On the other extreme, we have the patients who are all over the internet and try to become experts in prostate cancer when they're diagnosed. But this would not be a rare situation. Because he's mildly symptomatic with bone pain, I would tend to start with a GnRH pure antagonist to certainly not exacerbate his pain. And then obviously he would be an ideal candidate for apalutamide.
So I'm sure it will come up as part of a discussion, but intensification just from moving to mono to doublet therapy is one thing, but is this someone you would consider, quote, triplet therapy with additional chemotherapy plus an AR targeted agent?
That's a great question. I mean, that's really a fundamental question. Do we do doublet or triplet? Obviously, this program is primarily about doublet therapy with ADT plus apalutamide. He certainly could be a candidate for triplet therapy with adding docetaxel here to this patient. The fact that he has little family support does concern me a little bit, whether he would be able to get through the chemotherapy. I think that maybe it's biased, but I would tend to try to keep it a little more simple for him and, consider an oral therapy. Because he has diabetes, I would be a little bit reluctant to prescribe abiraterone because of the need for steroids, but the diabetes is certainly something that might make me lean more towards an agent like apalutamide that doesn't require steroids.
Yeah, and I think you point out that's really all of us can agree that moving from 1 agent to 2 agents that's the first step, low-hanging fruit we need to do. Whether you move from 2 to 3 is a very nuanced individual discussion per patient. And you can see here that there is overall survival benefit in both high volume and low volume. That has obviously been the concern, is some of the previous combination therapies, especially with chemotherapy, did not show as much improvement in low volume patients. And as a result, there was a tighter window for risk benefit for those patients. But on one side, we see high volume, 30% reduction in risk of death. On the low volume patients, a 48% reduction in the risk of death. And so the low volume patients, it was a smaller subset, as Judd mentioned, about 2/3 of the patient were high volume on the trial. And the definitions per charted, it's down at the bottom of the slide. But for those who are listening in, the definition is at least 4 or above bone lesions with 1 outside the vertebral column and or having visceral disease. So this patient that we presented with a liver met would certainly count as a high volume patient. All right, so I'm going to turn it back over to Judd to run through kind of the idea of the triplet and impact of chemotherapy.
So this is a subgroup analysis of patients who've been previously treated with docetaxel. Now, this is a subgroup analysis. Only 11% of patients in the Titan trial received prior docetaxel. And you can see the disease characteristics in patients who received prior docetaxel. 3/4 of them had high volume disease. 62% had bone-only disease, 16% had visceral disease, and 60% had greater than 10 bone lesions. So this subset were the real deal with advanced prostate cancer. And again, like the other data, most of these were patients that just presented de novo with bad metastatic prostate cancer. This is looking at the patients who either had the docetaxel or didn't with regard to overall survival. And I think the key teaching point is that we don't see in this subgroup of 11% of patients who receive docetaxel, we don't really see a clear survival benefit in this group compared to the patients who did not receive the docetaxel. So now you get to discuss the fun stuff of PSA kinetics.
So that's certainly what some of the doctors and the patients really want to see. Patient-stimulated anxiety or physician-stimulated anxiety, however you want to think of it. But I think we're all aware of the fact that PSA responses drive a lot of our care, and PSA responses can be a signal about what could come to that patient down the road. So this is a different sort of patient, 66-year-old presenting with metastatic castration-sensitive prostate cancer. Here is somebody who's an engineer, which certainly could happen in a college town like Durham, that's keeping track of his own PSA levels, diagnosed with prostate cancer 5 years ago, had prostatectomy. And you can see here clinical factors in the middle of the slide, a Gleason score of 7, 3+4 with a PSA of 7. And now the bugaboo of a PSMA PET scan that shows 3 spinal mets and some nodal mets. So he is technically metastatic castration-sensitive prostate cancer by the PET scan. Certainly, these patients in our practice, we would offer them intensified therapy without even having conventional imaging. He is, from a social standpoint, they put in here that he's looking forward to be active. He wants to spend time with his granddaughter. He's getting ready to retire. And so he's not already retired sitting at home with nothing to do. And so he's very focused on quality of life issues. And the comorbidity that they list here is hypertension, which almost any of the AR-driven drugs can influence. So we just try to make sure that they have a cardiologist who can help manage those. But what he's going to be super focused on, and Judd can probably attest to this too, is what is my PSA doing after I start my medication? The Kaplan-Meier curve presented here is different than a overall drug curve from our study. So every patient on both of these lines is getting Erleada on study. The difference between these two lines is the top patients are patients who had a PSA 90, which is a 90% decrease in their PSA from baseline, or achieved what amounts to an undetectable PSA of less than 0.2. And so you can see they do not reach the median, even as you get out close to 4 years. Those patients are doing very well. And so underneath that is the curve showing the patients who do not have a good PSA response. And with that, the median time until death event is just over 3 years. So if you have somebody whose PSA is 7, like this poor patient, and he starts therapy and he goes to 0, great. He's on the top curve. If his PSA drops from 7 to 2 or 3, that's a red flag that it's probably going to start rising, and you're probably having to look at subsequent therapy much sooner because he's going to progress. And so I think that's how we tend to use this PSA. It's more of a, if you reach that threshold, it's reassuring. If you don't reach that threshold, we still keep you on the drug until you progress, but we watch you much closer. Judd, what's kind of your takeaway with PSA education for these sort of patients?
That was a great discussion. I think this is one of the most important data points that we're discussing this afternoon because, for the listeners, whether they're a urologist or an advanced practice provider, monitoring this PSA post the initiation of apalutamide with ADT, is really important. And we have an opportunity to identify Well, to identify the good patients and reassure them is really important. That's satisfying in practice to have that positive conversation with a patient if their PSA drops below 0.2. But the point is this is really important. You need to get that 4, 6, 7-month nadir PSA to see where it's at.
Yeah, I think it builds on a lot of old Dr. Hussein published initial just on monotherapy ADT. If you don't do well with your ADT response, it's a signal that it is bad disease. Now, the caveat of that is patients who start on an ADT monotherapy and get sent into my clinic and their PSAs already dropped very well, I then have to oversell them to some extent that that's great, but your duration of response is not going to be the same on monotherapy ADT. So you can't feel totally comfortable. This is all these patients were on combination therapy. So don't feel like if you're on monotherapy ADT and reach that PSA low level, you're on that top curve. That's not, unfortunately, the way it works. All of these patients were out of the ERLEADA arm of the study. And then this is just kind of separating out at 3 months and 12 months. What are the patients who reach 50, 90 undetectable PSA? And you can see it's much higher rates of reaching those thresholds in the ERLEADA apalutamide arm, which is the darker blue, versus the placebo ADT arm, which is the lighter blue in the slides. But it's about 2 to 3 times a higher rate of achieving those rates of decline. And so you're putting more people into the categories that signal you're going to have a good response. And you're already on the therapy that's been shown in the overall population to have a survival benefit. So it's really nice to be able to tell patients, if you go on this combination therapy, it is a more than 50% chance that you're going to have an undetectable PSA as we get out to a year, because that really strikes home for the patients who are anxious. And this is all comers. So this is not someone who started with a PSA of 7. This includes people who start with a PSA of 1,000 or 3,000. So it's really important in those really high level PSAs that we drive it as low as we can. And Judd, I'll turn it back over to you to kind of summarize what we've gone over today.
Great. Thanks, David. The TITAN study enrolled a broad population of patients with clinically high risk de novo features, such as high volume prostate cancer, including 12% of patients with visceral metastasis. So again, the key teaching point, these were men with real metastatic prostate cancer. Most of them were just presenting to their urologist with mets right from the get-go. The combination of apalutamide plus ADT is a chemosparing regimen in metastatic castrate-sensitive prostate cancer that does not require concomitant chemotherapy. So what we're trying to teach is that this is a combo or a doublet that delivers a survival benefit that you've seen. It demonstrated a 35% reduction in the risk of death when compared to ADT alone. So this is combined androgen blockade in the current era that actually delivers a survival benefit after a median follow-up of 44 months. So this is pretty longer-term follow-up. Most patients who were treated with apalutamide plus ADT achieved an undetectable PSA in 3 months. And as Dr. Morris just alluded to, we had more than half of the patients still maintaining an undetectable PSA a year into this. So over 60%, I think. At the final analysis, the safety profile of apalutamide plus ADT was consistent with the primary analysis. And as I said earlier, the previous Spartan trial had studied apalutamide in detail in metastatic, non-metastatic castrate-resistant prostate cancer. And the TITAN trial followed up on that, but there were no new major or significantly different safety signals. Apalutamide is now available as a 1 pill once a day formulation. How do you see this reduced pill burden benefiting certain patients in your practice?
So I think it's in the right patients, it's hopefully going to be something it's no cost difference, and it makes it much simpler. I know our patients, size-wise, the pill is not really that much larger than the other pills. So to be able to take 1 tablet a day could be a win for many of our geriatric patients.
I've really enjoyed the opportunity this afternoon to work with Dr. David Morris and present this information. For the audience, don't go away yet. We have some additional safety information that has to be shared with you. But at this time, Dr. Morris and I are going to end our presentation. And thank you very much for being part of this.
Important safety information. Warnings and precautions. Cerebrovascular and ischemic cardiovascular events. In a randomized study, Spartan, of patients with mCRPC, ischemic cardiovascular events occurred in 3.7% of patients treated with Erleada and 2% of patients treated with placebo. In a randomized study, Titan, in patients with mCSPC, ischemic cardiovascular events occurred in 4.4% of patients treated with Erleada and 1.5% of patients treated with placebo. Across the Spartan and Titan studies, 4 patients, 0.3%, treated with Erleada and 2 patients, 0.2%, treated with placebo, died from an ischemic cardiovascular event. Patients with a history of unstable angina, myocardial infarction, congestive heart failure, stroke, or transient ischemic attack within 6 months of randomization were excluded from the Spartan and Titan studies. In the Spartan study, cerebrovascular events occurred in 2.5% of patients treated with Erleada and 1% of patients treated with placebo. In the Titan study, cerebrovascular events occurred in 1.9% of patients treated with Erleada and 2.1% of patients treated with placebo. Across the Spartan and Titan studies, 3 patients, 0.2%, treated with Erleada and 2 patients, 0.2%, treated with placebo, died from a cerebrovascular event. Cerebrovascular and ischemic cardiovascular events, including events leading to death, occurred in patients receiving Erleada. Monitor for signs and symptoms of ischemic heart disease and cerebrovascular disorders. Optimize management of cardiovascular risk factors such as hypertension, diabetes, or dyslipidemia. Consider discontinuation of Erleada for grade 3 and 4 events. Fractures. In a randomized study, Spartan, of patients with NMCRPC, fractures occurred in 12% of patients treated with Erleada and in 7% of patients treated with placebo. In a randomized study, Titan, of patients with mCSPC, fractures occurred in 9% of patients treated with Erleada and in 6% of patients treated with placebo. Evaluate patients for fracture risk. Monitor and manage patients at risk for fractures according to established treatment guidelines and consider use of bone-targeted agents. Falls. In a randomized study, Spartan, falls occurred in 16% of patients treated with Erleada compared with 9% of patients treated with placebo. Falls were not associated with loss of consciousness or seizure. Falls occurred in patients receiving Erleada with increased frequency in the elderly. Evaluate patients for fall risk. Important safety information continued. Warnings and precautions continued. Seizure. In 2 randomized studies, Spartan and Titan, 5 patients, 0.4%, treated with Erleada and 1 patient treated with placebo, 0.1%, experienced a seizure. Permanently discontinue Erleada in patients who develop a seizure during treatment. It is unknown whether anti-epileptic medications will prevent seizures with Erleada. Advise patients of the risk of developing a seizure while receiving Erleada and of engaging in any activity where sudden loss of consciousness could cause harm to themselves or others. Severe cutaneous adverse reactions. Fatal and life-threatening cases of severe cutaneous adverse reactions, SCARS, including Stevens-Johnson syndrome, toxic epidermal necrolysis, SJS-TEN, and drug reaction with eosinophilia and systemic symptoms, DRESS, occurred in patients receiving Erleada. Monitor patients for the development of SCARS. Advise patients of the signs and symptoms of SCARS, for example, a prodrome of fever, flu-like symptoms, mucosal lesions, progressive skin rash, or lymphadenopathy. If a scar is suspected, interrupt Erleada until the etiology of the reaction has been determined. Consultation with a dermatologist is recommended. If a scar is confirmed, or for other grade 4 skin reactions, permanently discontinue Erleada. See dosage and administration. 2.2. Embryo-fetal toxicity. The safety and efficacy of Erleada have not been established in females. Based on findings from animals and its mechanism of action, Erleada can cause fetal harm and loss of pregnancy when administered to a pregnant female. Advise males with female partners of reproductive potential to use effective contraception during treatment and for 3 months after the last dose of Erleada. See use in specific populations. 8.1, 8.3. Adverse reactions. The most common adverse reaction, greater than or equal to 10%, that occurred more frequently in the Erleada-treated patients, greater than or equal to 2% over placebo, from the randomized placebo-controlled clinical trials, Titan and Spartan, were fatigue, arthralgia, rash, decreased appetite, fall, weight decreased, hypertension, hot flush, diarrhea, and fracture. Laboratory abnormalities, all grades, grade 3 to 4. Hematology, In the Titan study, white blood cell decreased ERLEADA 27%, 0.4%, placebo 19%, 0.6%. In the Spartan study, anemia, ERLEADA 70%, 0.4%, placebo 64%, 0.5%, leukopenia, ERLEADA 47%. Important safety information continued. Adverse reactions continued. Chemistry. In the Titan study, hypertriglyceridemia, ERLEADA 17%, 2.5%, placebo 12%, 2.3%. In the Spartan study, hypercholesterolemia, ERLEADA 76%, 0.1%, placebo 46%, 0%. Hyperglycemia, ERLEADA 70%, 2%, placebo 59%, 1%. Hypertriglyceridemia, ERLEADA 67%, 1.6%, placebo 49%, 0.8%. Hyperkalemia, ERLEADA 32%, 1.9%, placebo 22%, 0.5%. Rash. In 2 randomized studies, Spartan and Titan, rash was most commonly described as macular or maculopapular. Adverse reactions of rash were 26% with ERLEADA versus 8% with placebo. Grade 3 rashes, defined as covering greater than 30% body surface area, BSA, were reported with ERLEADA treatment, 6%, versus placebo, 0.5%. The onset of rash occurred at a median of 83 days. Rash resolved in 78% of patients within a median of 78 days from onset of rash. Rash was commonly managed with oral antihistamines, topical corticosteroids, and 19% of patients received systemic corticosteroids. Dose reduction or dose interruption occurred in 14% and 28% of patients respectively. Of the patients who had dose interruption, 59% experienced recurrence of rash upon reintroduction of ERLEADA. Hypothyroidism. In 2 randomized studies, Spartan and Titan, hypothyroidism was reported for 8% of patients treated with ERLEADA and 1.5% of patients treated with placebo, based on assessments of thyroid-stimulating hormone, TSH, every 4 months. Elevated TSH occurred in 25% of patients treated with ERLEADA and 7% of patients treated with placebo. The median onset was at the first scheduled assessment. There were no grade 3 or 4 adverse reactions. Thyroid replacement therapy, when clinically indicated, should be initiated or dose adjusted. Drug interactions. Effect of other drugs on ERLEADA. Co-administration of a strong CYP2C8 or CYP3A4 inhibitor is predicted to increase the steady-state exposure of the active moieties. No initial dose adjustment is necessary. However, reduce the ERLEADA dose based on tolerability. See dosage and administration. 2.2. Important safety information continued. Drug interactions continued. Effect of ERLEADA on other drugs. CYP3A4, CYP2C9, CYP2C19, and UGT substrates. ERLEADA is a strong inducer of CYP3A4 and CYP2C19, and a weak inducer of CYP2C9 in humans. Concomitant use of ERLEADA with medications that are primarily metabolized by CYP3A4, CYP2C19, or CYP2C9 can result in lower exposure to these medications. Substitution for these medications is recommended when possible, or evaluate for loss of activity if medication is continued. Concomitant administration of ERLEADA with medications that are substrates of UDP glucuronylyl transferase, UGT, can result in decreased exposure. Use caution if substrates of UGT must be co-administered with ERLEADA and evaluate for loss of activity. PGP, BCRP, or OATP1B1 substrates. Apalutamide is a weak inducer of P-glycoprotein, PGP, breast cancer resistance protein, BCRP, and organic anion transporting polypeptide 1B1, OATP1B1, clinically. Concomitant use of ERLEADA with medications that are substrates of PGP, BCRP, or OATP1B1 can result in lower exposure of these medications. Use caution if substrates of PGP, BCRP, or OATP1B1 must be co-administered with ERLEADA, and evaluate for loss of activity if medication is continued. Please see the full prescribing information for ERLEADA, apalutamide.